Hello, everyone, and welcome officially to the International Deprescribing Journal Club hosted by the Portuguese Deprescribing Network. This journal club is the product of collaboration between the German, Australian, US network of European researchers in deprescribing, European Society of Clinical Pharmacy, the Portuguese Deprescribing Network, and the Canadian Medication Appropriateness and Deprescribing Network. My name is Luís Monteiro, and I will be your moderator for this session. I'm a family physician with a PhD in medicine on the strategies to improve the quality of prescription in older adults. I'm also an associate professor at the University of Aveiro. As a researcher, I enjoy teamwork to ensure the best patient care. A bit of housekeeping before we get started. To help us ensure good audio quality during the speaker's presentation, please keep your microphone muted. Because not everyone is able to attend live, especially since we are living in different time zones, we will be recording these sessions. Please take note that this recording will be posted on our YouTube channel later today. The information on the recording will be posted on this website, and you can also consult this webpage to view all previous journal club sessions. Now is the time to introduce our speaker, Dr. António Teixeira Rodrigues, has expertise in pharmacoepidemiology, public health, and health economics. He serves as invited assistant professor at the School of Medicine at the University of Minho and as director of the Center of Health Evaluation and Research. He has collaborated with national and international institutions, including iBiMED, in the University of Aveiro, the Health Economics Unit at the University of Birmingham, and Instituto de Saúde Ambiental, Faculty of Medicine, University of Lisbon. Now it's time to hear our speaker.
Thank you, Luis. Thank you very much. Hello, everyone. Let me share my slides. Okay, so I think it's already working. Yes. Okay. So thank you again, Luis, and thank you very much to all the institutions that are part of this international network, which is really, really nice and interesting. It is a great pleasure for me to be here today on this International Deprescribing Journal Club. Well, just a brief introductory note. I'm here presenting a paper which the first author is Sonia Romano, and I'm here today on behalf of her. She's the first author of the paper, and unfortunately, she could not be able to be here today because she actually is defending her PhD thesis tomorrow. This paper is part of that PhD thesis, and I think she has a very good excuse to not to be here today with us. Well, I'll try to answer to any questions or comments that you may have about this research, although not with the same expertise, pretty sure that as she would do. Okay, so the work I'm presenting today, the title is Effectiveness of a Collaborative Deprescribing Intervention of PPIs, proton pump inhibitors, like omeprazole or pantoprazole and so on community dwelling older adults, the C-Senior Pragmatic Non-Randomized Control Trial. I'm here representing a fairly large research team, obviously one I would like to acknowledge now, and this paper was recently published in Drugs and Aging. Just some notes about the conflicts of interest. Some of the authors here are affiliated to the National Association of Pharmacies in Portugal and ANF. This association supported the study, but it had no role in the design, implementation, statistical analysis, or conclusions of the study. So, some introductory notes. Well, PPIs, proton pump inhibitors, are among the most widely used classes of medications. Nowadays, evidence suggests that 40 to 85% of long-term use of PPIs may lack an appropriate indication. Well, long-term use of PPIs has been associated with adverse outcomes such as fractures, CKD, and other complications. With some exceptions, nowadays, clinical guidelines recommend using PPIs at the lowest effective dose and for the shortest duration possible, typically 4 to 8 weeks. Well, regarding deprescribing, I will not go into detail about deprescribing or introductory notes about deprescribing in this forum, but I would like to highlight two key points. The first one is that at the time when we started this research, evidence on PPI deprescribing remained inconsistent and context dependent. On the other side, there was a clear need for a patient-centered and multidisciplinary strategies to improve medication use, specifically about PPIs and in primary care settings. Accordingly, the aim of this study was to evaluate the effectiveness of this collaborative intervention involving community pharmacists and GPs in prescribing inappropriate proton pump inhibitors among community-dwelling older adults. So, about the methods. Well, this study received ethical approval, the trial was also registered, and the study protocol was previously published at +1, as you can see on the right side of the slide. Okay, the study design. Well, the trial was a pragmatic, multi-center. It involved several primary healthcare units and the community pharmacies around them. A non-randomized controlled trial with a 6-month follow-up, as you can see in the figure here. Well, why a non-random versus a random design study? Well, a randomized approach was not feasible in this study because the intervention was developed based on the interest of 2 family health units, these primary healthcare units involved here in Portugal, that were willing to collaborate with community pharmacies. In addition, the small number of pharmacies around these primary healthcare units was the number of pharmacies was quite small and made randomization in each one of these primary healthcare units impractical. So about the study population, well, the inclusion criteria included community dwelling older adults with 65 years or older, with an access to a telephone. We needed the telephone to do the follow-up contacts, as you will see in the design of the study, and using PPIs for more than 8 weeks. Were excluded from this study those living in nursing homes or assisted living facilities, unable to communicate or speak in Portuguese, or with any kind of cognitive impairment or any condition limiting the understanding of the study evaluated by the community pharmacist. Okay, so about the intervention group. Well, 2 family health units, primary health care units, were included in the intervention group. Around them were found 9 eligible pharmacies to be invited to the study. All of them were invited and 8 accepted to participate in the study. Regarding the control group, the process was actually a bit more complex. Well, we used the geographic matching approach to identify municipalities that were as similar as possible to those included in the intervention group. So first, we compared the municipalities across Portugal using indicators such as purchasing power, population aging, and illiteracy rates. Then, within these matched areas, we identified family health units based on their organizational model, which means financing model, and the PPI prescribing rates, and ensuring that they were comparable to those 2 included in the intervention group. And finally, last but not least, we included a larger pool of control municipalities comparing with the intervention group and number of pharmacies too, to balance recruitment between groups, because lower participation was expected in the control arm comparing with the interventional arm. As you can see in the figure, on the top of the figure, 17 family health units were included in the control group, 61 pharmacies around them were eligible to participate in the study. All of them were invited. 17 were accepted to participate in the study. Okay, The rest of the flow chart is the figure 1 of the paper and shows the details of the number of participating family health units, pharmacies, and patients. At the baseline, we had 21 pharmacies, 8 in the intervention group, 13 in the control group. In the intervention group, 87 patients were recruited. At baseline, 79 in the control group. Okay, now let's take a look at the intervention itself. We developed this multifaceted intervention involving a collaborative pathway between community pharmacists and GPs. The intervention had 3 main components. Well, it starts here at component 1 at the community pharmacies. Firstly, community pharmacists identified and recruited patients who had been using PPIs for more than 8 weeks, as I told you in the study population. They assessed whether the treatment might be inappropriate or not by self-reporting by the patient, and also provided oral and written information about PPIs to the patients. All this information was shared with the GP, and at the moment this information was shared with the GP, component 2 starts. Here, GPs reviewed the patient's clinical information and medical records, evaluated the need for continued PPI use, and discussed, using a medical consultation with the patient, whether or not to continue or deprescribe the medication, following national guidelines. Again, the data on the deprescribing decision took by the doctor was shared with the community pharmacy, and component 3 starts. At component 3, pharmacists were informed by the GP's decision of the GP decisions that was took with the patient, and conducted the follow-up phone calls to monitor deprescribing, supporting patients during the withdrawal of the medication. Okay, about the outcome measures. Well, the primary outcome was successful deprescribing, and it was defined as the discontinuation or dose reduction of any PPI at 3 or 6 months. Okay, regarding the secondary outcomes, we have several. We assessed beliefs about PPIs using the BMK specific questionnaire, which assessed necessity and concerns about the medication. We assessed medication adherence using the 7-item Likert scale, health-related quality of life through AQ5D5L, and also self-reporting of adverse drug events, number of long-term medications, polypharmacy, drug-drug interactions, and last but not least, and actually very, very important for an intervention that aims to be patient-centered, the patient satisfaction about the intervention, which was only assessed for those in the intervention group. Finally, before going to the results, some notes about the sample size and statistical analysis. Well, we calculated the sample size expecting, based on the literature, at least 20% difference in the prescribing between intervention and control group, and then we performed an intention to treat analysis, estimated risk differences, relative risks, and the number needed to treat. And we also analyzed the secondary outcomes using difference in difference methods. I won't go further here on the statistical detail, but if there are any questions, we can come back to this in the Q&A moment. Okay, so regarding the results, this is a classic table 1 of a trial like this. So as you can see on the column on the right, it's quite small, I know, but it's the p-value of the comparison of the baseline characteristics between intervention and control group. No significant differences were found between these two groups. The population had, on average, 74 years old, 59% were female, and also important, the use of PPIs were in median 10 years already. Those patients were using very long exposure of PPI in the population included in the study. Regarding the primary outcome, at 3 months, 50% of the intervention group successfully deprescribed their PPI, compared with only 5% in the control group. Well, this corresponds to a 46% absolute risk difference, number needed to treat 2.2, and a relative risk of 9.6. The intervention impact on 3 months at 3 months follow-up point was huge. The number needed to at 6 months, as you can see here, the effect remains stable. 48.8% of patients in the intervention group successfully deprescribed versus 5% in the control group. Okay, regarding secondary outcomes, no statistically significant differences were observed between intervention and control group in any patient-reported outcomes or drug-specific outcomes, such as adherence, as you have here, health-related quality of life, adverse drug events, and all the others. Actually, according to the literature, several systematic reviews have looked to the impact of deprescribing on these patient-reported outcomes, and the overall evidence has been mixed or actually limited. In addition, our study was not powered to detect the differences in these secondary outcomes, and we actually would need a much larger sample size to do that or to identify that. However, I would like to highlight one interesting result here, which is the one associated with the BMK questionnaire. We assess this patient's beliefs about PPIs, looking at how they are balanced between their perceived need for the medication against their concerns using this questionnaire. And as you can see here, we had huge differences at baseline between intervention and control group, but at 3 months follow-up, the differences were not statistically significant, but the results are quite interesting also. Okay, so discussion, main findings. Well, this trial was effective, reducing proton pump inhibitors used at 3 and 6 months. These findings align with previous studies using collaborative approaches aiming at reducing inappropriate PPIs. And I would like also to highlight here that the intervention might have been more effective if it had targeted only patients without a clinical indication for long-term PPI use. Actually, patients were included based on their PPI use more than 8 weeks, since pharmacists did not have access to full clinical records. About 30% of the patients were advised to continue treatment, and by the other side, 70% were advised to stop or reduce their dose, highlighting the high prevalence of inappropriate use. Okay, about strengths and limitations, I will focus on limitations. We had this non-randomized design, which may introduce selection bias, the smaller than planned sample size, 170 patients versus 222 that was calculated, but we did not reach the planned sample size due to these real-world recruitment challenges, which likely reduced the power for secondary outcomes, for sure, but the primary outcome remained robust and statistically significant. The intervention was implemented in some specific geographic areas, and some deviations from planned procedures, like delays in medical appointments and incomplete follow-up, may also have affected the results that we got. To conclude, well, collaborative GP pharmacist models should be promoted. Better communication systems and access to clinical records could improve the deprescribing effectiveness. And last but not least, further research with larger samples, particularly to assess the impact on those secondary outcomes, is needed, and also a longer follow-up to understand the impact, potential impact of this kind of projects. And that's all. Thank you. Thank you all for all. Thank you all that have participated in the project, but particularly to the community pharmacies, to the GPs, to their institutions, and the patients that have agreed to participate in the study. And now I'm available for any comment or question that you may have.
That's right. Now is the time to dive into the Q&A portion. A kind reminder to please enter your questions in the chat or to raise your hand if you would like to share a thought or a question verbally.
Luis, I try to not to keep my presentation too long, otherwise it's very hard for everyone to keep attention, but...
That's right. Okay, we have a question from Clementine, right?
Yes, hello. My name is Clementine. I'm a
Hello.
pharmacist from Canada, and I was wondering if your pharmacist, your community pharmacist, has any um, type of patients that they were targeting to the prescribing PPIs, because in some of my practice, it's kind of hard to detect which one should get the prescription for PPIs or not. I'm sorry, my English is not the best.
It's perfect, Clement. Yeah. I don't know if Luis I can add something to your question, Clementine, which well in the way we designed this intervention, no, we only have the information that is available at the pharmacy at the moment when we are attending the patient at the community pharmacy. And all the information we used was or self-reported by the patient or some data was available at the software system in the community pharmacy. But to decide if the patient is eligible or not to be part of the study was only self-reported information. And the most important one was the use of one of these medicines for more than 8 weeks. And as I emphasized in the discussion, we believe that we had like 30% of the patients who, after medical appointment, the GP told them to continue and not to deprescribe the PPI. And obviously, these are the cases where probably if we had more data, or more clinical data, or at least some information about the indication to what they are using the PPI, we could avoid including these patients because it will decrease the effectiveness of the intervention and even actually it creates another contact with the doctor, which should be avoided. But we were not able to do it. However, the rate of inappropriate use of these drugs is so high that the intervention keeps to be very effective. Actually, I don't know if Luis wants to add something, but
Yes.
yeah, please go ahead.
As a family doctor, what I think is important is that we know that patients use PPIs for a long time, and sometimes we don't know why. And I think the key element here in this research, as other researchers found, is that communication do works, even if it's by paper or by telephone. It doesn't actually need to be an AI communication. What we do need is for patient security and safety to communicate more. I think that's the main goal here.
Thank you. So it's because I'm a hospital pharmacist, so the communication is different from community pharmacist. I was a community pharmacist in my time, and we have some patients, as you said, that we don't know why they're taking PPIs. So it's our job as hospital pharmacists to make an history of the medication that was taken. And sometimes we see that people are not taking it, like they'll be taking it for a long time, but it's still relevant to take it. So that's why I was just seeing if the communication with the GPs how were they during the study, because it's kind of hard sometimes to know. So thank you for your answers.
Thank you for your question. Yes, but it's a challenge. It's a challenge. We have another questions from Nus, I think.
Yes, hello
Go ahead.
everyone. My name is Nusha. I'm pharmacist from Slovenia. I would like to ask, maybe I missed how communication with the GPs was established. Like, was it established in advance? and were they like presented what the study will be about before inclusion or not, and how then later communication was managed between GPs and pharmacists and also with patients. Thank you.
Thank you very much for your question, Nusa. Well, about the GP's engagement, well, we developed this intervention, collaborative intervention with 2 family health units, primary healthcare units here in Portugal, which were led by very engaged GPs already. They were aware of the importance of this kind of projects, and they were keen to participate on them. So it was easier for us to have, because we had their leadership to their peers about the importance of participating in this project. So this is why this is a quasi-experimental study. It was not randomized, because on the intervention arm of the study, we have these 2 primary healthcare units who led by GPs that were very engaged on the project. About the communication during the project, the communication between GPs and community pharmacists, unfortunately, and we have all this detailed in the paper, but unfortunately, we were not able to have a software system sharing the information between community pharmacies and the GPs. So instead, we have used the clinical research associate. We have a person that used this patient passport, which was a paper-based dossier, which guarantees that all the information collected at the community pharmacy goes to the GP, and after the medical appointment, the information comes back again to the community pharmacist. It's not a very good way of doing it. It was the way we had to do it, because we weren't able to guarantee that we were able to put the operating systems working together, because it's quite simple information, but we were not able to guarantee that it would reach from one setting to the other one. I don't know if I answered everything, but the question was quite broad, but very interesting. Thank you.
Yes, thank you very much.
We have another question from Rivka, right? And Camille wants to talk also.
I'll let Rivka go first, or actually, I think they're in the waiting room, so I'll ask my question. Thank you, Antonio, for this great presentation, and thank you, Luis, for moderating. And congratulations on how successful the intervention was. I'm so impressed with those rates of reduction. I'm wondering if you were able to compare this rate of success with other trials, and if it sparked you to kind of identify like where these high rates of success came from. Maybe that's the first component of my question. And then the second component would be, and I'm sorry if you touched upon this and I missed it, were you connected, or we talked about the role of the pharmacist and the GP? Was there any intervention from nutrition specialists, dietitians, to help patients, also improve? I know this is only one component of PPI use, and we can reduce it through many lifestyle changes, but the food intake and, in terms of how that can spark symptom, is that something that GPs are used to doing in Portugal, or is there also a role for dietitians or nutritionists, depending on how you call them?
Okay. Thank you, Camille, for your question. I will ask for help to Luis to answer you, but I'm not sure if I'm fully aware about the literature in this area. We have some references about other projects similar to this one that are already published in the literature, and the results are, I would say, quite similar, also very impressive. But as far as I know, it happens when you have both collaborative approaches with both GPs and community pharmacists, and also multidisciplinary and multifaceted interventions with patient education, shared decision-making. Actually, the shared decision-making was in one of the meetings that we had with the GPs, one of the coordinators of one of these healthcare units told us that this shared decision making was absolutely crucial for the success of the intervention, because when they start talking about this with their patient, the patient already knows a lot about it, coming with that information from the community pharmacy. But answering directly to your question, yes, as far as I know, there are some, I would not say similar, a bit different, but focus on PPI deprescribing with huge results also when they have this multidisciplinary, multifaceted approach. Okay, regarding the
I would just
second, yes, please.
just to explain that, I think the reality here in Portugal is similar to other countries, I guess, because when we ask if deprescribing is an issue that doctors are feeling as important and actually integrate that in their workflow, family doctors and internal medicine are the doctors that are actually very worried about this issue, about optimization medication, about starting the right ones and stopping with as a process and as a multidisciplinary approach. We family doctors are increasing this issue also when I teach in the university and also in junior doctors. Our residents are starting to have awareness of the prescribing, and all this network that is starting now is a reality, but it's obvious that we have a long time to go. I will also add that continuity of care helps this approach. I mean, if the patient, as in Canada and other countries, recognize the same family doctor for years and the same local pharmacy, it's easier for this approach to have success. And that's why it's not, I believe, but also the evidence shows that continuity of care gives health to our patients.
Camille, regarding the second part of your question, just to let you know that we had some materials, education materials, they are actually in the supplementary documents of the paper with some kind of this counseling regarding nutrition and lifestyle habits. They are not like and then they were implemented in the follow-up by the community pharmacist. We did not have the intervention of other healthcare profession, but that would be very, very nice, because one of the aspects, one of the main barriers that we found for not deprescribing is the symptoms that some patients felt after the prescription itself. So just to let you know that the intervention had these features, but not additional ones.
Yeah, that's great. I was just looking through and I like seeing them, so I'm sharing them with the everyone here so people can see what type of materials were shared.
Yeah, but they are in Portuguese. They are not validated in English, so they had to be published in Portuguese.
Of course,
Yes.
it makes sense, but we can still understand. It's very,
Yes.
yes, looks great. Thank you for your response.
Any other questions on the chat? No? So if you don't have any other questions, I would like just to add that you can visit our this website for any updates about the next Journal Club session. We are now launching a final poll to know if this session met your needs. We want to know, were you satisfied with this Journal Club session? What portion of the session did you most prefer? What is the likelihood of you re-attending the Journal Club session? Thank you, as this was very helpful for us to continue to improve future sessions. You may have more questions for our speaker or comments that you aren't shareable with the Zoom multiple answer poll. You may also want to be involved with the planning of future journal club sessions, I want to just want to suggest a future topic or research. If so, we invite you all to write us at this email or Twitter or Facebook. Thank you again for attending this session. We hope to see you at our next session. And I must add that this session wouldn't have been possible without the participation of the different groups. And thank you all and every one of these members for their help.